All right, it's 2 o'clock, so we'll go ahead and get started. My name is Jennifer Youngeman, and I am from Woolsey, South Dakota. Bonus points if you ever have any clue where that's at. But today we're going to be presenting dialysis access, overcoming complications through evidence-based practices. Our speakers today we have with us is Forrest Rawls. He is a CCHTA, is the Vascular Access Coordinator for Emory Dialysis Clinics in the Atlanta, Georgia area. He is responsible for all access issues for 4 clinics. He has presented numerous times at NKF, ASDIN, VASA, NANT, and CIDA. He is very compassionate in caring for ESRD patients. He is also the second author on numerous papers regarding vascular access, particularly the use of ultrasound in the dialysis clinic setting. The next speaker we have then is Nakia Davis, nurse practitioner. She is 24 years of experience in nephrology and extensive work across the dialysis methods. She advocates passionately for kidney health education, actively participating in the organizations like American Nephrology Nurses Association, National Kidney Foundation, the American Kidney Fund's Health Equity Coalition. Nakia has chaired ANNA's Diversity, Equity, and Inclusion Committee and serves as NKF's Advocacy Committee, working to improve kidney care accessibility as ANNA's Michigan past president and health policy representative. She has outreach along with the Chi Edify Sorority Incorporated, educates faith-based groups on kidney health every March, annually called Kidney Sundays. Nakia promotes prevention and awareness for her work, underscores a commitment to advancing kidney health through advocacy, policy, and community empowerment. Our third speaker then is Dr. Vandana Nayar. Is a professor of medicine in the Division of Nephrology and has received her clinical distinction of Master Physician at Emory University. Dr. Nayar is passionate about promoting multidisciplinary collaboration in research and education in the field of vascular access, with the ultimate goal of optimizing access care and processes for dialysis patients. She currently serves as the immediate past president of the American Society of Diagnostic and Interventional Nephrology. Dr. Nayar has been recognized for her exemplary clinical and service achievements through various awards, including ASDIN Distinguished Service Award in 2019, Emory Nanette Wagner Service Award in 2009, ASN Mid-Career Distinguished Clinical Service Awards in 2020, ANIO Clinical Excellence Award in 2021, Emory DOM Outstanding Quality Achievement Award in 2022, and ASDIN Gerald Brethard Award in recognition of her teaching excellence, scholarly activity, and clinical excellence in 2024. Please welcome the speakers to our session today.
Well, thank you all very much for coming. And since this is an interactive session and very interdisciplinary, as you guys can see, what we are going to do, we have quite a few presentations, but you have those slides available to you. So we really want to make this very interactive, because what you want to look at is when you're looking at the access of a patient, there are so many layers and levels involved, right from the person who first sees the access to the technician, to the nurses, to the physician, and we are here to provide that perspective today. So what we want to do is we will go through one PowerPoint. We have 3 PowerPoints, but instead of wasting time on just unidirectional, we are just going to do it, make sure that you guys can have all the questions you need answered when you are either rounding in the dialysis unit or cannulating or taking care of these patients. So just by a show of hands, so we understand the audience, how many physicians are in this group? Okay. How many nurses? How many technicians? And how many nurse practitioners? And is there anyone I missed? Dietitians, social workers? Okay, so it seems like we have a great representation of the people that are on this stage. So what we would like to do is start with Forrest. I have the extreme privilege and honor of working with Forrest. He is the dialysis technician for our unit, and he is in charge, literally, of vascular access at Emory Dialysis. So I'm going to let him start a little bit, giving you an idea of what his role is as a vascular access coordinator, and then we'll start with the questions. Throughout this, whenever we see a good segue, we are going to have a PowerPoint because we do want to, am I not loud
I don't
enough?
see anything. No, you're fine.
Okay.
Can I go ahead and open this?
We were not going to actually, we were going to do an interactive session, but go ahead and open it if you want, I
They
think.
don't want to do video in here.
Oh, got you.
So we can just do it from here, but it won't automatically advance, will it?
It won't.
It won't.
Okay. Or maybe I just stop the slideshow and leave this slide here. Yeah, that's fine. So while we're fixing that, Forrest, if you want to, or you can take the mic there, right there in front of you.
Actually, I like to stand up better, but I'm
Okay,
okay.
stand.
I'm fine. I'm fine. Okay. Before I ruffle any feathers, nephrologists, I see we have a few here. Most nephrologists, not you guys, okay, don't really work with vascular access. You agree? You agree? Okay, so what I mean is that nephrologists round typically in a dialysis clinic after first shift. They don't see accesses when they're being cannulated. Very important. So technicians, usually in the United States, are the ones who do the cannulation. So they need to learn how to speak up and say, listen, doctor, this, or nurse, this is what's going on. Because by the time the doctor usually gets to the situation, you have a problem. So I like to be proactive rather than reactive. So I got that out of the way. Okay. Now my job as a vascular access coordinator, I do a lot. So let me start with basic what I do. I teach how to assess a fistula. And it has to be done every time, not sometime, and it must be done correctly. So at our clinics, we have a protocol where 20 seconds to 30 seconds is all you need. When the patient comes in for dialysis and they stand up to get that standing blood pressure, get ready, because when they sit down, you've got about 20 seconds to do look, listen, feel, augmentation, and arm elevation. If you do that every time, I've taught people and patients as well how to find and detect different problems. If you find things out ahead of time, you'll save the patient's access and yourself a lot of time. Instead of guessing, well, I think it's okay. No, you'll know. Another rule I have is everybody has to have a stethoscope. It's kind of hard because I ask technicians and some nurses, how'd you cannulate this patient without a stethoscope? So I always ask the patient, no, they never listen. So you have to always be mindful of everybody's not gonna be like Danny and myself. We were in the Navy, so we go by rules. We have protocols, right? Everybody doesn't follow that. Okay, so before I talk about a typical day, because there's never a typical day. There's never a typical day in access. So what I want you to understand is that we use ultrasound-guided cannulation, so I'll talk about that later. But after you do the basic assessment, you have to be like a coach. You have to understand it from the patient's perspective, the technician, the nurse, and the doctor. Okay, now I already mentioned that the doctors usually don't come around, so you have to talk with your nurses, and you must be able to communicate with everybody on a level that they comprehend. You cannot talk to some patients in a way, you have to talk to everybody different. You have to feel them. Since I'm retired from the military, I talk with military patients very easy. It's too easy. It's just, we flow. So first of all, you have to find out what type of access they have, what's the issue. Now, CMS wants us to have catheters over 90 days, and that's it. But when you have patients who come to you with accesses which are with a catheter, it's hard to make that fistula graft materialize and work within 90 days. It's real hard. So if we get some of those, but we don't get a lot, we're trying to do better. So when these patients come in from day one, they meet me and we start talking about access. They've already had the modality choices before they come, but you have to start talking access right away. Day one, as soon as I get the name, we go. And you have to present it to them in a way that they can comprehend. And you don't want to scare them off by, oh, if you keep that catheter, it's going to get you infected. You can't do that. That comes later. You really want to get them in the mood to be receptive to getting permanent access. That's first. Any questions so far? We're all right? Okay. Now, after you've gotten through that barrier, you have to know what type of patient it is. I mentioned earlier to some people, the hardest patients I have to convince are prior PD patients. PD patients who've been successful for 6, 7, 8 years, and all of a sudden they get peritonitis. Not once, 4 times. Okay, the doctor makes a decision to put them on hemo with a catheter. They're my hardest patients. I still have some now, 4 years later. They will not let you make an appointment to get a permanent access. They're the hardest patients. They're so used to this freedom and all, and they won't go to home hemo. They want PD, so they'll come in reluctantly and no, just cover it up, just cover it up. And that's what they want. So you have to be where the patient is. You have to understand their desires. Although once a month I document that I go around, run on my mouth and talk to the patients about, the dangers of a catheter and how you need a permanent access. Let's talk about, question? Oh, no, okay. Let's talk about different accesses. And I'm going to go around and around, so this is dialogue, okay? Different accesses. As a vascular access coordinator, I try to teach, I teach everybody, you must know what type of an access you have that you're working with. Many look alike. No access is exactly alike. You can say fistula and graft all day long, they're different. So the staff needs to know what they're cannulating and how to cannulate it. For example, I showed some pictures earlier where the fistula looks like a graft. Some fistulas, wow, they look great. No, it's not a graft, it's a fistula. How can you tell? Look, you gotta look and see what's going on. Because fistula first came out and said, okay, let's get a fistula first, some surgeons were getting, okay, let's do this. Brachiocephalic, right, beta-cephalic. Let's do a brachiobasilic. And we all know they work, but it's 1 stage or 2 stage. Get that nice scar here, they lift it up, and you can go ahead and cannulate. People thought that was a graft. No. Doing the brachiobasilic, we've discovered that over a period of time, you're usually going to get stenosis up top, 6, 7 years, whatever. You're going to get it. But you have to teach people how to cannulate that because sometimes the scar is just where the access is. They didn't pull it over. So people say, oh, I can't stick that. No, that's where it is. And the scar tissue, keloid scar, that's skin. You can stick through it. So you have to teach people how to stick. The other thing is that the use of needles. We use 17, 16, and 15. We don't use 14 gauge needles at all. I was taught by different people that we don't want to put nails in people's arm. You really don't need a 14 gauge because KT over V can be established, and it does, by using actually 16 gauge or 15 gauge needles without being too traumatic to the fistula. And I'm talking, by the way, mainly fistulas. I'll get into grafts in a moment. But fistulas are unique, and the problem with cannulation is that Danny and I'm using Danny because we have 50 years apiece experience in dialysis, and we learned a long time ago, we learned on fistulas. And, told a tale. We learned on Scribner shunts. You ever heard of those? We learned on Scribner shunts. That's history. Then we learned on fistulas, okay? They came to vogue. And so fistulas, that's all we had. So somebody got smart and created a graft. That's where you started having a lot of your cannulation issues. Because the grafts, they don't mature, they're there. Stick them, Dano. Right? That's right, it's real easy, right? So then you had people in the 80s and 90s cross-train between both, and that's when you start talking about access cannulation problems, because people didn't know how to stick a fistula. It's very easy, but you have to be taught how to do it. Now, some variables besides, back to needles. Needles, the rule is 17 gauge needle on the fistula, 1 and 1. Of course, pulling one, returning to the other. And then you do that a couple of times and you mature up. Whether you stay at 16 or 15 is a policy that you guys choose. Okay, you don't really have to go to 15 gauge, and we'll talk about that later outside. 16 gauge are fine because CMS says KT over V should be 1.2. As long as everybody's 1.2 or higher, we're happy. But some clinics want it to be 1.4, 1.5. So you get a star for that? I'm just curious, what do you get for that? What happens? Is the assumption that the patient is getting a better dialysis because the clearance is better? I don't know. The government says 1.2. So that's what we do, 1.2. But that's clinics, am I right, ma'am? 1.2?
So we just
Go
want to
ahead.
stop and
Yes,
ask,
go
does
ahead.
everybody have that basic knowledge of this, or is this something that we should go step by step? Is there anyone who didn't understand what Forrest was talking about as far as needle size, needle gauge, and the blood flows? Should we just explain that, or is that good? We're good.
We're good?
Okay, so then good.
All right. So, oh yeah.
First, the 1.4 is set by usually corporate standards, and your quality measures are in accordance with those corporate standards, not,
Yes,
not agency.
I understand. I'm saying CMS says 1.2.
And historically said 1.2, but FMC, for example, said 1.2.
Correct.
Yeah, and that's, I understand that, but I'm a Navy, I go by the book.
That's what it is.
Yeah, 1.2 is the book to me, but I understand that. So that's, okay, I shouldn't have mentioned that, but that's what it really is. Okay, so what size needles should we use after the 17 gauge? Use a 16 gauge. You know, they come in 3 different sizes. Everybody's aware of that. 3/4, 1, and 1 1/4. So people ask me often, well, what size should we use? That's based upon the length of the fistula, okay, and the size and everything. And I make the determination what size to use. Wet sticks versus dry. I was told by Dr. I didn't ever say this, so I won't. I've never stuck a patient with a wet stick. Y'all know what I'm talking about? Say that you need to, I never have done that. So I made a statement. She said, no, never say that. You know what I'm talking? I'll say it. I said, I would never stick a fistula with a wet stick. Don't say that, don't say that. So I say, I don't do it. So when people ask me, new technicians, I say, look, I don't have a preference. Whatever you do to get the needle in and it works, I'm happy. So see, that was a bias of mine because I learned in the military, you don't do that. So old habits, but it works. So I'm not, it doesn't bother me on that. Whatever size you want to use is okay. As far as the depth, you know how it goes in. The depth is very important. But the deal is whether it's wet or dry, okay? As important, cannulating and access, you must secure it real good. When I walk around and I see a piece of tape hanging up, I get upset because no, if you've ever seen a venous needle or arterial, but especially venous, come apart and shoot across, you learn from that one time. They're all going to be taped down. Don't be afraid if a person has adipose tissue and they perspire. That little tape is not going to hold it. We know that. Go ahead and do it. Cover it up. I don't mean cover the access. I mean tape it down securely. You must do that. You must do that. Now, having talked about the needle size and the cannulation, I tell people however you hold the fistula is up to you. I do it different, you do it, we all do it different. Whichever way is comfortable for you. Some cannulation camps or clinics, they teach you how to hold it. I can't do it that way, but whatever way you get the needle in, that's the importance, how you get the needle in. Now, I also teach the patient to know about access. They have to know what they have, and they have to know 3 things. Now, we all know, I believe in this room, when you have some problems with an access that, like stenosis or whatever, they give you the stethoscope, you listen, and you're supposed to listen for the sound, the whistling sound, da-da-da-da, shh, and all that good stuff. I don't do that. I simplified it. Okay, we're gonna do dialysis today. I'm gonna show you how. Listen, see that? That sounds good, doesn't it? Okay, so if you do that with all your patients, then all you have to do is, hey, this doesn't sound right. That's so simple. The difference in the sound is the key. If something's wrong, listen again, something's wrong. And how to ascertain whether you have inflow stenosis or outflow stenosis is important as well. Because if you don't assess an access, a fistula, and you have inflow stenosis, then you want to know why the machine keeps going off, arterial pressure, because you didn't do an augmentation test. It didn't pass the test. So why not do it from the onset? The same thing with venous pressure going up. Excuse me. You want to know why the patient's bleeding for 35, 40, 50 minutes. Well, they've got a stenosis. You could have detected it right away. You could have detected it right away. And these are just basic things that I do all the time. Other things are, let's see, any access questions so far? We're okay? We're on point? Okay. You need to know about how appointments are made. How do you make appointments? And where to send the patient and why? You do know we have vascular access centers or surgical ambulatory centers, and we have surgeons. At the centers, we usually have interventional radiologists and interventional nephrologists. I just call them interventionists, okay? And we know their main function there is to take care of, let's see, changing catheters, angioplasties, thrombectomies, and sometimes stent placement. That's their soup. That's what they usually do. They're not surgeons. Surgeons do a plethora of other things. Now, we have some situations where patient needs to go, but what do you do? If I have a patient who has a fistula which is relatively new, I really don't prefer an interventionist to put in a stent. You know why, right? Anybody know why? No. Stents, if you keep using a stent, you're going to stent up the access. It's not going to work. It's not going to be productive. So I prefer to send the patient back to the surgeon who did it so they can do a revision. So they can revise it and keep it going. Now, if you have an elderly patient, I'm 72, but I'm not old, so I'm talking about me, right? Who has our, quote, raggedy access. And they have they're old and frail. Okay, not to blame them. But if they have a raggedy access, okay, you might want to consider getting them a stent placed versus surgery, especially if they have a heart problem or any other comorbid conditions. That makes sense? So you do that. Now, I'm very lucky because my nephrologist, we have rapport. We have rapport. I was at a meeting and I asked some technicians, how many of you, by show of hands, talk to your doctors? 3 people out of about 400. 3 people were the only technicians who talk to the nephrologist. And nurse practitioner or the person who's doing that, okay? I don't leave you guys out. I'm sorry. So, but how can you not talk to the doctor? Okay, the rules say technicians cannot assess. Well, you get around that easy because I don't assess. I identify and report. What is that? That's an assessment. But I identify and report. You just change the word, but you do the same thing. And you must let people know what's going on when it's going on. Now, let's see, more about access. What else do I do? You had a question? Oh, you're just saying hi? Okay, yes, go ahead.
So I just started floating not that long ago. I've only seen one other tech that actually listens to the access. Other than myself, I've only met one other tech who actually listens to the access.
See?
When I float. And so I've gone to clinics where all here is stenosis, and the pressures have been off, and nobody has listened to it. But I wanted to ask, I know listen for the Brewy and feel for the thrill, but I was never taught how to assess beyond that. So
Okay.
Okay.
Perfect. Yeah. Say the question one more time. You want to know how? I'm sorry.
How do you assess, other than listening and feeling, how do you assess like raising the arm?
Okay.
Well, we could just,
You got it, Dr. Nate?
yeah, I think.
Okay,
So.
go ahead.
Do you want to do it?
Go
I
ahead.
can do it. We have slides on that too, or do you
Yeah.
guys want to just,
How
because
you wanna do
Forrest's way of talking is very entertaining.
Is that good or bad?
And it's good, it's very educational, they won't forget it.
Where are the slides located? Because on the actual messaging app, or not messaging, the meeting app, it's not at the bottom like it was in the previous.
It's not, it should be, because we sent these in like
No,
month
I don't-
ago?
Yeah.
So we'll ask them. We'll make sure that, so do you want to,
It's whatever you desire. We can do it. Either way
Does
you want.
everyone understand the anatomy and the vessels that are used for access and the nomenclature and how to identify? So you just brought up that question of the symptoms and signs of a dysfunctional access, right?
Yes.
Yes, like, other than listening and feeling, what are the other steps, like raising, what are you looking for when you raise the arm?
Okay. So I'm just going to move this very quickly, just so that you know there are 2 arteries and 2 veins that we all have to do to create the accesses. And then obviously you've got the central veins that give us, the catheters. We'll move through these because if you don't have the slides, we'll make sure these slides are uploaded. And so Forrest talked about the look, listen, and feel. And basically what you always want to remember is that a fistula is a circuit that begins and ends in the heart. So it's the heart, the pressure, the cardiac output that really fills the fistula, because you've got an inflow and you've got an outflow of an access. And so when I'm showing you in a picture, and this is what you already know, right? This is the part that everybody knows, the look, listen, and feel. How do you feel for an access, whether it's a soft thrill or it's pulsatile or you hear a bruit, that's both systolic and diastolic, or can be heard only in systole. But the question that you asked was, how do you determine, and we'll just do this in 5 minutes and then go back to Forrest and Nakia, is early fistula dysfunction versus late. So whenever you have a new access that's placed, if it hasn't been used, that is early fistula dysfunction, or in the first 3 months. And most of the time, that issue is an inflow problem. So when we say inflow and outflow, inflow is what's going into the fistula, outflow is what the fistula is draining into. And all of that, like I said, is a circuit. So the easiest way to think of this is to think of your inflow as a tap and think of your outflow as a hose. So since we say it's all plumbing, right? Think about a tap, and we'll make this interactive so you guys will give us the answers, and that way you won't ever forget what the issue is. So if you have early fistula dysfunction, the problem is with the tap. The problem is with the inflow, whether it's a problem with the artery or the initial part of the access, which is called the juxta-anastomotic part, which means close to the anastomosis. So just imagine if you have a tap and you've got a hose, but the size of the hose depends on the flow that's coming from the tap. What do you think is going to happen to a hose if you just have a few drips of water coming in from that tap? Does that hose become bigger? So I see a lot of heads shaking no. What alarms will be on the machine? Because it's an inflow problem, and the problem is with the tap, which is the artery. It's your arterial pressures that will alarm. So when you're trying to evaluate for a good access and trying to make sure that the tap is on, what you want to do is, if you have a good inflow, if the tap is coming on with the full pressure and you've got the hose and you close off one end of the hose, what do you think is going to happen to the hose between the tap and the part where you occluded it? It's going to get bigger, and that test is called augmentation. So augmentation is a test that you should be doing to check the inflow of every access. And this is some pictures. So you guys have already given me the answers to an inflow stenosis. So if the patient has an inflow stenosis, the fistula will not augment. Even if you put up a tourniquet or all the pressure, if you're just having a drip, 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 it's not going to get bigger. It's not well palpable. You won't be able to cannulate it. Your arterial pressures will be abnormal. And this is what it looks like. So here you can see, let me just see if I can get because this pointer isn't working. So, yeah, okay. So do you see that? I don't want to go over Forrest's head.
Go ahead.
So you see, this is the artery, and this is the vein. This is where the anastomosis is being created. If you've got full pressure coming in through the artery, and you occlude it here, this part will get larger or it'll augment, and this is a test for inflow stenosis. So that means that the inflow is good. Here, if you see, because what the surgeon does is when they bring the vein down to the artery, they torque it. And that causes that narrowing or that stenosis or that injury to that vein. So even if there are 2 times that you won't have good flow. Either the artery is poor to start with, but that should have been identified preoperatively. The surgeon should have done the Allen's test, should have made sure that the arterial, there's no calcification. If they've done it correctly, but they've brought the vein down here and there's a narrowing here, when you try to augment it, it's not going to get bigger. And that tells you that there is an inflow stenosis, and you can actually, by your physical exam, figure out where exactly the stenosis is anatomically. And this is what it looks like on an angiogram. So here you can see this, just to orient you guys, this is the forearm. This tiny thing is the artery. And here you can see the vein has come over here, and there's a narrowing here. And we successfully, it takes a small balloon. All you have to do is just inflate it up there. Of course, there are certain side effects to angioplasties too, but if you angioplasty it, you can actually get a successful outcome. And then this patient, when you do the physical examination, you'll be able to see the augmentation. And another reason why a fistula doesn't mature is if there are accessory veins. So we see this mostly in radiocephalic fistulas, where you have lots of veins in the arm. Now, does anyone know the difference between an accessory vein and a collateral vein? Okay, so the accessory vein is physiological, a collateral vein is pathological. So think about it the easiest way, again, trying to correlate it to life. If you have traffic on the road and there's a blockage, you're going to have to go around the road, right? So that is a collateral because there is a problem. So once you open up the stenosis, so you see this on a patient's chest when they have central venous catheters over a long period of time, you'll see lots of veins, but you don't want to call those accessory veins because they are collaterals who have developed because there is a problem, there's a narrowing. If you open up that narrowing, collaterals should disappear. Accessory veins are physiological. They're just multiple channels for the blood to flow through. We typically do not ligate accessory veins unless they create a problem and not allow the main channel to develop. So you want one big pathway that you can actually cannulate consistently and repeatedly. If you can't do that, then you have, if the blood is being stolen away from the main channel and doesn't allow it to expand, then you have what we call multiple accessory veins. And if we want to ligate them, it's very simply done. You just look at it with an ultrasound, put a little suture around it, and you're done. Or you can coil it. So it's a very easy thing to fix. But most of the times, unless I find the accessory vein is taking too much blood away, I do not ligate it, because if you close off one of the channels, the chances of venous hypertension for the patient in the long run is higher. So don't fix anything that isn't broken if you don't need to do that. And then talking about late fistula dysfunction, which is the other test that we talk about, which is collapse. And so what do you think will happen if you have, so what should happen to a fistula? Like I said, it's a circuit that begins and ends in the heart. So the blood should flow directly into the heart. If I raise the fistula above the level of the heart, it should completely disappear. It should look like a normal arm. If it doesn't, it does not collapse. And so if a fistula does not collapse, that tells you that you have venous outflow stenosis. So again, the hose has a kink in it or has a narrowing in it. So now you've got an area that you've got a good inflow, you've got a good tap, you've got this hose, and you've got a kink in the hose. What do you think is going to happen to the pressure within the circuit? It's going to be high, but because it's an outflow, it's a venous pressure. So this time, it's the venous pressure that's a problem. The other thing is you put in 2 needles in this axis, and when you take the needles out, what do you think is going to happen? The patient is going to bleed. And what you're looking for is a delta, right? There are patients who are bleeders. They'll always bleed for 30 minutes. There are patients who will always bleed for 10 minutes. What you're looking for is a change in the bleeding pattern where a patient tells you, the alarms on my machine were going, they're giving you all the clues. The alarms on my machine were going off. Obviously, you'll see on the labs, the clearance isn't good enough because you're trying to push the blood past the stenosis. And then the patient says, I used to bleed only 15 minutes, but last night I spent all night in the ER because they couldn't stop the bleeding. And if the ER isn't well versed with dialysis patients, like if there are very few dialysis patients or they're in a minority, they will be looking for Eliquis, heparin, all of those things. That's not the problem. The problem is within the access. So again, know what your inflow is. Think of your inflow like a tap. Think of your outflow like the hose, and then you'll be able to look at all of these and be able to identify these early. And that's important because once you identify them, the fix for them is relatively easy. So here's what outflow or collapse looks like. And here you can see that the fistula is really prominent here. And as you raise it, it sort of becomes, and so you should try doing these in the dialysis units, but of course the best time to do it before the patient gets on the machine, or they have a catheter that they're dialyzing with. And as you can see, very easily fixable. This is obviously not an optimal result, but this has certain other things, like a cephalic arch stenosis has some issues. And you can see this, like Forrest was saying, it's a ratty axis, and it looks so much better after you. So now this is a question for everyone. This is a loop graft. And when you cannulate a loop graft, you have to put in your needles in certain ways. How do you know which limb is arterial and which limb is venous? So, right. So for those who didn't hear, press at the apex of the graft. The side where you have the tap or the hose coming in will become more prominent, more pulsatile, and that is your inflow. And the side which is blowing out will actually become collapsed and you'll barely be able to feel it, and that is your outflow or your venous stick. Okay, and we'll just touch a little bit of aneurysms, and then the floor is Forrest and Nikia's. So when should you start looking at aneurysms, and when should you start getting worried about them? What are the things that you're looking for?
You want to wait till it gets to number 3? No, I mean, really.
Go ahead.
In large areas, especially if there's tight, thinner, or tighter, thinner skin or scar tissue starting to develop on them.
So that's a great point. As the skin, as the fistula becomes enlarged and people look at sizes, so what we've started doing is we start sending the patients to the surgeons even before other things happen, just an increase in size, so they can take pictures and put them in the epic chart. And then really monitor them, because what you're looking for is a 25% increase in size, but that's something that you at the bedside may not be able to see or be able to calculate. So what she just said was that you're looking at the skin. And what happens to the skin as it becomes thinner, shinier, and yes, hypopigmented. So the skin becomes lighter. And you can actually, when you feel these axes where there's a defect, because you think of your fistula, you've got a vessel wall, you've got the subcutaneous tissue, and then you've got the skin. So as you're losing all of that and the fistula is enlarging, you can actually feel the dip, and you can feel how the skin is really thin on the axis. So size, shiny, and everything else. And then we've got a fistula here that we actually had, and Forrest is going to tell some really great stories after this. So you've got a brachiobasilic fistula, and you've got the arterial anastomosis here. You've got this large aneurysm, and it starts oozing a little bit, or there's a scab. What do you think you should do next? I'm sorry, I didn't hear what you said.
Call surgery.
Get them to the surgeon immediately.
Immediately. And so you are going to send the patient, especially if it starts even a trickle of an ooze. That is a medical emergency. So what is the blood flow in your arm without an access? So without an access.
Without.
If you don't have an access, no, it's around 100. 80 to 100 mils per minute in an arm, like in my arm, perhaps. Mm-hmm. What is the blood flow, the minimum blood flow for a functional access? 600, right? The rule of 6s. But on an average, most accesses have how much? Over a liter, a liter and a half. What is your cardiac output? Approximately 5 to 6 liters. So you have 4 or 5 minutes before, if an access ruptures, before the patient bleeds out. So you have to, when you put your patient in the ambulance, you have to tell your patient what they need to do if the access ruptures on their way. So what we do when we round in our dialysis units, every patient with an aneurysm that looks kind of iffy to us, we teach our patients how to get hemostasis if the access should rupture. And where do you think, so if the fistula ruptures right here, what do you think you guys are going to do? Okay, what did you say?
Hold pressure below at the anastomosis.
Okay. So turn off the tap. The impulse is you see the blood spurting out from the hose and it's a large amount of blood. You want to plug the hole, which you can also do. There are guidelines from the United Kingdom that came out 3 years ago that said if you take a bottle cap, like a Coke bottle cap, and use that to plug the fistula and just tie something around it, you've stopped the hole and nobody's holding pressure that it's not leaking. But the foolproof thing to do is to actually occlude the anastomosis, turn off the tap. Okay, Forrester.
Okay, since you went right there, we'll start with there. We have I like real scenarios.
Before we get started, she said below the anastomosis, but you said
She said add the anastomosis. She said below the rupture, add the anastomosis. So the other thing that most people say is put a tourniquet up here. Because they see, so if the fistula, the aneurysm is here, the anastomosis is here, a lot of people feel like if you put a tourniquet up here, you'll be able to, because they're thinking arterial flow, which is what they would have done if the patient was in the field and had a, like a leg lac or something like that. This is what you would do because you want to stop the artery. But here the connection from the artery is going up. So it's a little counterintuitive, but that's what you have to always remember is turn off the tap.
So to locate the anastomosis, we have to look for a scar.
So that's a good question. You do have a scar. Now some people heal very differently. So we might have patients who heal with keloids and the scar can hit you a mile away. And there are some patients where the scar after a few years disappears.
Right.
So you have to know, and we sort of jumped over the anatomy part, but you'll have the slides. But you have to know where the anastomosis is. So for radiocephalic fistula, there's very few fistulae in the forearm, right? It's a radiocephalic or an ulnar basilic, or if you create a Gratz or an endovascular fistula. In the upper arm, the confusion comes with a brachial artery cephalic, brachial artery basilic, which is done in one stage, and each doing it in one stage or 2 stages also have their own advantages and disadvantages, and you have to decide which is the right access for your patient. But keep in mind that most of the times, unless you are looking for an axillary, like a necklace graft or an axillary loop, 80 to 90% of the time, you'll either have a brachial artery-based anastomosis or a radial artery-based anastomosis. So if you're unsure and you can't figure out where it is, just put your hand on both those things. I mean, if there's more than one person. But what we teach our patients is to know where the anastomosis is. And we teach them how to feel when there's no flow in it. So you don't want to really occlude an access for more than 5 seconds. But the patients immediately they light up because you show them how to do it and the flow through the access completely goes. Any other questions on this part? Yes.
So I have noticed sometimes we'll accumulate an access that we're confident there's no issues with, and then every once in a while the pressures will be kind of higher, we'll feel resistance when we test it. But if I pull it back just a little bit, then it's fine. So I always assumed that's because we're up against a wall, but I was thinking the other day that veins have valves and a fistula is built on a vein. Is it possible that that sometimes you're feeling that resistance because you're up against a valve? And is there a way to know exactly where those valves are before you cannulate?
So I'm totally biased, but I would say ultrasound.
Ultrasound,
But then
that's
we
right.
are a huge proponent of ultrasound and cannulation, but
You
no,
just-
there's no way to actually know until you're in there. The one thing that we get a lot, and everybody will say that, is when people say they're pulling clots. So if someone tells you, like we were rounding yesterday, or before you came, Monday, I think we were rounding at the dialysis unit,
Yes.
and the patient told me, they said we are pulling clots. That immediately should tell you that they are not in the lumen. They're not in the true lumen. So if they are half in and half out, when you're pulling clots, and all you need to do is reposition the needle. Pulling clots does not mean the patient has a clotted axis.
Right.
It just means that the needle isn't in the true lumen of the axis. You just need to pull that out and do it. And obviously everybody follows the modified baseball rule in dialysis for cannulation. So what's the baseball rule? How many strikes and you're out? So modified baseball rule, 2 strikes and you're out. So basically everybody can have a bad day. I do procedures, that's all I do. I can have a bad day. It doesn't matter. There's no ego in that. 2 strikes, if you tried it twice, let somebody else come and try it. Or I always say 9 times out of 10, it's not the cannulator, it's the access. So it's not, I would just follow the modified baseball rule. Yes.
I have a patient who have a radiocephalic fistula that has no outflow and they've been using it for like 5 to 10 years. So because there's no problem at all. So when there was an outflow stenosis and they did a fistulogram, they discovered that for 5 or so years, the fistula is draining not into the cephalic or basilic vein, but in collateral. So now, eventually, because it is like 8 to 10 years old, the fistula started to develop aneurysm similar to that. Is it advisable to have it repaired to save the fistula since there's no outflow, or is it necessary to create a new one?
So I would say that's an excellent question. Did everyone get the question? Okay, so basically someone who's really dialyzing through collaterals and you're obviously getting an adequate clearance, otherwise they wouldn't have continued it. The problem with that kind of fistula when you don't have an outflow and something that's been going on for that long is that even if you repair it, like again, everything in life is a risk versus benefit ratio, right? So if I repair the access, the patient is going through surgery, but still prone to venous hypertension, and which is probably going to get worse as I sort of, ligate it. I would go to the other side in this particular case, but the one thing that I would try is a couple of things. So if you can cross the stenosis, and which is everybody sort of, it's when the stenosis is fresh. So we are talking now about, so I'll just give it 2 minutes on central venous stenosis. So I assume this is a central venous stenosis that the patient has and is now draining through collaterals or through the azygos or something else.
The central vein is okay, but it's just that the cephalic and the basilic vein are occluded.
So if cephalic and basilic are both occluded, there still has to be a channel that goes into the central veins, right? And so there are multiple things that can be tried in the right hands. So not everybody can do this. One is called an inside-out technique. But keep in mind, for central venous stenosis, you really, if a patient is asymptomatic, so let's say I'm doing an angiogram for an outflow stenosis of a fistula, and I see a central venous stenosis, I do not angioplasty that. You don't do a drive-by angioplasty of a central venous stenosis because every time you inflate the balloon, you cause a little bit of inflammatory reaction. That's called neointimal hyperplasia. And so there was a very nicely done study 7 or 8 years ago that showed us that if you angioplasty asymptomatic central venous stenosis, 30% of the time the patient will become symptomatic just as a result of your intervention. So you don't want to angioplasty people, blindly, but if the patient has central venous stenosis and it's acute, on the angiogram, what we'll see is a narrowing, which is like an arrow. I can usually get my wire down that. If the narrowing is more curved and more round like this, I can try everything. There's no way I'm getting a wire across it. So I can come at it this way, but I can come from below. So there's a new technique that, in the old days, the radiologists used to try from below, and the success rate was 10%. The inside-out technique that was actually developed by a cardiologist 5 years ago is where they can actually go in, put in a wire through, and then actually have it come out through the chest between the first and the second ribs, and then thread their catheter through that. So it's a little complicated, done by not many people. In this Metro Atlanta, we have one person who does the inside-out technique. So you have to know the right person to refer your patient to, and they can try getting past that stenosis. If they get past the stenosis, maybe we can repair the access. If they can't get by the stenosis, I would not recommend that we repair the access, because you're just creating problems, and it's better to move to the other side or to move to Necklace, Hero. There's lots of other options as well. Any other questions? Forrest?
Okay.
Or Nikki?
Yeah. Okay. This situation here, impending rupture. Well, I like real scenarios. Came in the clinic and I saw something, didn't know what it was, but it didn't look right. So I told the tech, I said, no, we're not going to cannulate today. Huh? But I cannulated Friday. No, we're not going to cannulate today. It didn't look right. So she's bilateral amputee, and her husband brings her to the clinic. I said, listen, you need to go to the emergency room, call your husband. Okay, so I kept looking. I said, wait a minute. Okay, I said, okay. So she went to get in the car, put her hand here, and guess what happened? Whew, oh, man. So I said, wow. So anyway, they did this. I got a bottle cap. First time I used it. Perfect. Put the bottle cap on there, wrapped it around. The surgeon at the hospital told her, according to her, who did this? They really know what they're doing. So this stuff works. It encases it right here, and it really works. Now, some techs saw it. I said, listen, this is not prolonged bleeding. Don't get it. No, it is not for prolonged bleeding. This is for rupture. There is a difference. There's a difference. So people who have suspect, in my opinion, like this, I will tell them, look, I'm going to give you this, but it's on the way to the surgeon, just in case. We learned that, and that really works. And you'd be surprised. When I mentioned it at another meeting, they were like, really? That's a good idea. And it really is. So when you learn things from other people, England, it really works. Okay, that's that part. The other thing is, what were we talking about before you came? Oh, when doing the evaluation of the arm, not sometime, every time. That's the key. Every time. We're unique because our round with Dr. Nair, we do rounds on that. We do access rounds. Too many times a week. No, I'm kidding. We do this all the time. We do rounds. So what happens is we get to see what's going on, and she makes decisions right away. So one day we were in a clinic real quick, and she noticed 3 in a row. I called her after she did. She said, Forrest, is our prescribed blood flow rate 300? No. Just come here. I said, no. So when you see a 300 blood flow and a 280 venous pressure, everybody knows what's going on, don't we? What's going on? Say it again.
Infiltration.
No. I can't hear you.
Somebody said it.
I can't hear you.
Venous stenosis, outflow stenosis.
No. What this case was really is they didn't take the time to cut the blood pump off and readjust the venous needle. And you can always tell that halfway through the treatment, you're still running at 300 or 280 blood flow. It hadn't gone up higher. So what happened is cut it off, readjust the needle, and you can turn the blood flow to the prescribed rate. And I was embarrassed because she saw it. I'm like, come on, you guys, what are you doing? That's being lazy. You're not doing the patient a favor. You really need to take your time. We need to take our time and do a better job of that. That's the situation. And anytime we see situations which aren't normal, you have to have someone in the clinic who can do it. In our case, that's me when she's not rounding, and we converse every day, all day, whenever she's not doing her other thing. And we get the best for our patient. Something else she's taught me is that although you're concerned and you take care of the present access, always, always, always be mindful that this may not last forever. Be on the lookout and be prepared for alternate sites for other access. We had a guy who had 4 fistulas, transplant, came back with a catheter. So I said, well, she said, no, Forrest, think. I said, oh yeah, helo graft. So he now has a helo graft, see? And they work. We have another patient has helo grafts. We have 2 helo grafts. They do work. So you always have to think, what is the option? Because all my patients, when you tell a guy, especially the men, that they have to have a femoral graft, they're not going with that. They want an option. They do not want a femoral graft or thigh. They don't want it. So you have to be able to give them options. So helo grafts, that's one. Also talking about grafts for a moment. You can jump in when you want. Grafts. There are grafts that are different. Okay, years ago we used the bovine graft. Well, now we still use it, but they dressed it up, put some cellular tissue in it, and they call it what? The autograft. The autograft is a bovine graft, which acts like a fistula, but it's not. And you can use a slight tourniquet, but it works well. Although they call it a bovine graft, it's a carotid artery of a cow. That's what it is. Then you also have the newest person on the block called AccuSeal, or immediate stick graft. I was at a conference and the first time I saw it, I said, excuse me, I said, why does that have a 17 gauge needle in it if it's a graft? Good question, because it specifically states you need to start it with a 17 gauge needle. The problem I found out from some interventionists with that type of access, it's a thick wall, so they have a tendency to thrombose. But it's still better than having a catheter. Still better than having a catheter. Anytime you can get rid of a catheter and have a viable working access permanent, you're doing pretty good. Now, jumping to, go ahead. Yeah, go ahead.
I just want to piggyback off something that Forrest said as far as the patient's vascular access and the staff at that particular day that was lazy to readjust, needles on patients. I just want to reiterate that these accesses are our patient's lifeline. So we need to be cognizant of things that we do to the patient and making sure they're educated. I try to educate all my patients so they know what should or should not be done to them at our home clinic or if they go traveling or anything or anywhere else. So I've seen pressure dressings on patients. The other day when I was rounding, I saw a patient had 3 pressure dressings on at the same time. So she had to get an extra needle, and then they left the needle in apparently throughout her treatment, but then pulled all 3 needles out at the same time. Like, that's crazy. So if she's clotted when she comes back, I mean, that doesn't make sense to me. So I'm constantly trying to educate the staff about what should be done and what should not be done. Now, we have vascular access coordinators at our clinic as well. And I used to be a technician before I became a nurse and before I became a nurse practitioner. And I was a vascular access technician, way back when. But it was not on the level as, Forrest. Everybody wants a Forrest in their clinic or have access to him. But the way they select the vascular access coordinator is somebody who can cannulate well. And that is not all that is, that a vascular access coordinator does. Like, you have to have the knowledge and the information to know how to teach, other people, know how to teach the patients, and try to have our patients have longevity with their accesses. Most of these people are going to be on dialysis for the rest of their life unless they pass away or decide to quit. And even if they get transplanted, we know that's a treatment and not, a cure. So we need to try to prolong our patients' access is as long as possible, and us not doing things to them that's gonna, make their life, short, because we'll be going on about our business and about our lives and our families, and these patients, they have limited time on each time they have to get, a new access. But I just wanted to get that in before we got, too far with our other stuff.
Let's talk about some more complications, because they all occur. We've all seen a lot of them. We have a patient who comes in with an infected fistula, day one on dialysis. Oops, had to get a catheter. Got a new fistula, never worked. Got a third fistula. Third fistula, brachiocephalic, is maturing. The nurse called me and said the catheter's not working, so, we got a catheter exchange. The next day, the catheter's not working. Catheter exchange. Monday before I left to come here, I rounded. Catheter's not working. I said, stop. So I called the nephrologist, and they agreed. What I did, I looked at the ultrasound, and I saw a little portion of the fistula. Although it has stenosis up here, I saw a portion here. I said, we can do this. So you know what I did, right? What did I do? I did a 17-gauge needle right away and a return to the catheter. And the nurse said, wow, what made you think of that? You gotta do it, because most people don't do that. The thought is that the fistula is not mature. But if you've got an area where you can go arterial, I didn't say venous, and it worked. So then Tuesday, I don't know, but we went to IR on Tuesday. These are some things you have to do. You have to do them and think about what you're doing and why. You always get permission, but you'd be surprised. The nephrologists, once again, they really thank me because, and especially Dr. Nair, because they don't know. And it's okay. They ask me all the time, what do you think we should do? And I make my suggestion, and they usually go with it. I'm not going to do wrong. Now, let's talk about catheters for a moment, and then we go back to grafts. Catheters, we hate them, but we have to live with them, right? Here's the problem. Some of my nephrologists don't mind flipping the lines. Y'all know what I'm talking about, right? I have two of them. They're adamantly opposed to that. If they see that, get them out of here. Give me a new one. That's just what they do. Also, you need to know, when the doctor prescribes, let's say, a blood flow of 400 for a catheter, that's not really what you're getting. You do know that. You're not getting that. So when they're going down to 300, that's the best I can get, 250, let us know. We recommend Activase or some type of medication which is going to prolong it, but you probably have to get it exchanged. And like she said, getting catheters exchanged all the time is not good. We used to have clamps. I had to exchange 2 catheters because the clamps had broken. Wow, you can't get that repaired anymore. They used to just give you a clamp and you put it on there. Now you have to get the catheter exchanged. You got to get the whole thing changed. So here's another one. How long should an indwelling catheter, CVC, stay in on a chronic dialysis patient? There's really I don't think, any literature on that, all right? But let me tell you, when you have a patient who's had a catheter, no problems for 4 years, what happens when it has to come out? The patient told me it felt like, quote, they were taking my whole chest out. So he had refused to get a permanent access. So then, Forrest, please, I made him an appointment. In the meantime, at the new catheter, he's doing good. So they said, I changed my mind. Are you serious? So then they said, oh, Forrest, we got a problem. Arm swelling. The neck swell looked like he's a football player on the line. I said, hey, we got to do something. No access. Make a long story short, he swelled up so bad, so I said, look, we have an option. We can get you a helograph. So I made him the appointment. He went to the surgeon and said, are you going to guarantee this? He said, we can't guarantee this. I don't want it. So this morning at 5:15 in my hotel room, I got a phone call from the doctor. Forrest, guess what? His catheter, he had a femoral catheter finally placed. His femoral catheter is not working. Where do you want to send him? Now this is bad because this guy had a perfect chance to get a fistula graft a long time ago. And this is why I'm passionate about this. Now he has nothing left. Nothing left. Central vein stenosis, they're shot. So you can't even, it's horrible. Maybe the inside-outside may work, but it's horrible. And that's just real stuff. I like to talk real scenarios that really happen. So the most fun I get out of my job being a vascular access coordinator where I'm at is being able to be like a little detective, and you get to see things and make things happen. And it's all for the patient, because patients have enough. Talking about access centers. When do you refer a patient for an access issue? I need to tell you this. KDOQI guidelines 13.4 states, quote, that you do not need to send a person to an access center every 3 months or 6 months or every year. Did you guys know that? Some people still send patients to the access center every 3 months, like it's clockwork. And I know that good.
And we have access centers who say if we send somebody, there for a thrombectomy, and then they say, oh, they said I need to come back every, 3 months. So my nephrologist that I work with is no, completely against it. So, we tell the patient, no, you're not going back. If there's not anything wrong, there's no need to keep going back every 3 months for a tune-up, for a clean-out, for, all these different things. It's not necessary.
It's ludicrous because, go ahead.
Like monitor the flow, because if you monitor the flow month for every 2 months.
Oh, can I get on that?
Monitor the flow.
I heard you. I'm sorry. KDOQI guidelines also says doing access blood flow is okay. It's surveillance. But the number one is clinical assessment.
Agreed.
That's exactly what it says. So the clinics who do access blood flow, we did them. You find out that the day you do that access blood flow, it's fine. I've had people thrombose the next day. Now, it's good for trending sometimes, that you can catch it. But the best way is a clinical exam. Access blood flow, they had the nice lines and all, that works, but it's after the fact. If you do a good clinical assessment, right, Dr. Naim? Yeah, you can detect things. Good. Yeah, what else?
Well, based on it really depends on the patient, and, the guidelines are guidelines.
Yes.
What I have found is that for a subset of population of patients, the access blood flow over a period of 6 months can actually predict stenosis. Now I know the KDOQI, those were not, they were not prospective study. They were retrospective study. And so therefore, again, the quality of data the KDOQI, I don't know, I don't remember what it was, a C, or I have to go back and look at it.
Okay.
But there's a subset of patients in those we study, those that follow survey, where the following that I've been sending them, and the patient used to go and expect the class. Now it could be that they were going to close anyway, but it's just that group of people. As I see over a 6 month period or 8 month period that they drop in, they eventually clot if they don't go to the hospital.
So we used to do surveillance. We used to use the transonics 15, 20 years ago.
Yes.
A long time ago.
Long time ago.
And we would look at our data, and we looked for a 25% delta. So if there was a change in access flow, so Forrest would actually we used to be in the access center, and Forrest used to be in the clinics, and he would go around doing the surveillance, and then he would share the transonics data with us. And all the patients where the access flow dropped by 25%. But again, when you look, this is anecdotal, because we didn't really follow all of that. And whether we remember it because you remember those cases that, obviously don't fall within the norm. But the KDOQI guidelines, with all the literature, you're right, it's observational, it's retrospective, and whether it's for fistulas or grafts. And the other thing with surveillance is that surveillance adds. So Transonics was a company that used to make these devices that you could put on, and Forrest was very great at, because the big advantage, I think, of the Transonics was the simultaneous cardiac output. So
Yes.
in cases, so we can talk about high output failure after this, but in patients who we suspected high output failure, we could do simultaneous access flow and a cardiac output and know, what we're dealing with. But it now is very expensive to add to that, and whether the value is there, unless we have a proper study that looks at randomization or surveillance, in grafts versus fistulas, it's obviously different outcomes.
It's clear that the vascular access center make a lot of money doing that. And the cost benefit analysis hasn't been done.
Exactly. And the other thing that he pointed out is actually calling a patient, if a patient goes to an access center without an indication, is technically Medicare fraud. And there are physicians within even our area that have, really, there have been whistleblowers and things like that. So that's something that y'all need to keep an eye out for. If the access center tells the patient they need to come back, unless there is a clinical indication, the patient should not. It's not like going to the office for an office visit, because we are used to calling our patients back every 3 months. So when people transition to the access center, I don't think it was intentional, the physicians who did it. They just thought it would be a better way of following up on things, but it turned out to be problematic.
And we also have a surveillance program that we use. It's called Vascular, and where we, monitor patients' accesses. And then once that risk of thrombosis occurs, and that's when we kind of start sending the patients. If is a score from 1 to 10, and we start getting to 7, 8, 9, 10, this is when they need to be sent. And we have found that those people, when they're constantly having those alerts at those high risk scores, that they do end up, being clotted. But again, you still have to have that physical assessment, with it, the parameters on the machine, and all those different things. And
what do you use for high risk scores? We don't send people for surveillance every 3 months. We wait for a problem. But one of the things we do watch is initial venous pressures and arterial pressures to see if there's a trend that they're going up, and that we do use that as part of, maybe they need an ultrasound or, just go get checked out. So is that something like?
So that's the recommendation. So you're doing the exact right thing. So what the general literature supports it, and it's also, again, like you said, guidelines are guidelines, but monitoring. So there's a difference between monitoring and surveillance. Monitoring is things that you can do at the bedside. Surveillance requires different tools. So Transonics was a tool, Vascular is a tool. None of them actually, I'll be honest, have been validated. So what has been validated is a monitoring, and monitoring is a combination of physical examination and clinical signs. So pressures, the needle, obviously keeping in mind, if you're using a 17 gauge, you can't, and you try to get a blood flow of 400, you're going to have high pressures. But with the right size needle, the right pressure, and your, everything else that you're using, your labs, your physical examination. So physical examination is recommended to be done in all of those. So what you're doing is exactly right.
Great question. You have another one, sir?
Yeah. So I have a couple of patients where they're clotting frequently, and I just send them to hematology. And 4 to 5, they have a hematology disorder. But if they are clotting the fistula often, no matter what we do, then I actually send them to hematology to put them up.
Right. So if there's no anatomical reason for them to clot, and like we said, it's a circuit that begins and ends in the heart. So one of the anatomical reasons is if the cardiac output isn't good enough. So if the patient's blood pressure is 90/60 and you're giving them Magadrin, that is a problem with the pump, right? Otherwise, if you've looked at the circuit and there is nothing wrong with the circuit, so we had a patient who thrombosed multiple times and had a protein C deficiency. So the hematology workup will be the step. If you ruled out, a good pump and a good circuit, and then no anatomical abnormalities, then you need to look for other things. And there were studies that were done, there was a study from Canada that looked at giving either fish oil or giving, all of these Plavix or something at the time of the surgery. There was one study done at our center where they looked at giving vitamin D. So people have looked at all sorts of things, and so far there's no answer.
I train in Canada.
I trained in Canada.
I train in Canada.
Oh, you did? So you know a lot of the
So
stuff.
my studies do not have mathematics.
Yes.
Oh, so McRae and Locke and
Locke.
Moist. So they are the big group in dialysis who do all these studies, and they're trying. Everybody's trying to find out what it is that we can do to help our patients. But so far, we don't have an answer.
And just recently, we started putting people on Eliquis if they can. So my doctor gave me a study. I can't remember where it came out of. So that's something we're starting to do for people with multiple clotting episodes if they're a candidate for the Eliquis.
So I would
And-
take that anecdotally, like
Yeah.
I would not.
Yeah, I would-
Oh, yeah,
I
there's
want
gotta,
people to take that away in
Yeah.
this audience. So
Yeah.
that would be a risk versus benefit
Yeah,
ratio.
exactly.
Yeah.
And a discussion with the nephrologist, the surgeon, the radiologist, and the patient in the center before we make that decision.
And if the patient is going to be a transplant candidate, or there is a automatic reversal for the allopus, it's super expensive. So if they're really having a problem with clotting, then we put them on Coumadin because it's much cheaper to reverse it by communication.
Yeah, and you always have to think, which is an excellent point, every single patient who enters the dialysis unit, unless there's a contraindication, should be listed for a transplant.
Everyone.
And that's why the femoral accesses are also not a good option. So we have a pretty detailed review in C. Jason a few years ago where we talked about lower extremity accesses, and it's very critical for us to be, keep that anatomy, because the anastomosis with the iliac vein and everything down in the bladder, you really want to be careful when you use a lower extremity access. And most of the time people will come to you with two options when everything else is exhausted: a hero or a lower extremity access, and both of them have advantages and disadvantages that needs to be really thought about by the interventionist, by the surgeon, by the patient, and the long-term sequelae of each of those. So if the patient doesn't have a blood pressure, I would not put in a hero, because a hero is a connection at the artery, the graft, and a long outflow. And you don't get a lot of thrombus burden in a hero, but it clots because there isn't enough flow to push it through.
You have one, ma'am?
Yeah, just thinking of, so my clinic is very, very rural. We have no U-Haul.
Jennifer has a similar
She's the same way, yeah.
So if, looking at a clinic that's out in a rural area and, when a patient needs something, it's literally a helicopter ride somewhere when it's time. What would be like, if you said this is the most important tool at your disposal, other than a forest, because we don't have any of those.
We can clone forest, the future is here.
What would be like the number one thing that you would say, make sure that you have this in place to catch problems the earliest?
So
You want to start?
you start and then I'll add on to the
She's
other
going
part.
to, okay. I would say people need to be trained how to do an assessment. That's the start. And when you assess it, you can identify the problems now as opposed to later, when it's really going to be significant, where you have an emergent situation where you got to fly them out in a helicopter. That and I don't know, maybe you can find a nurse practitioner area who can do a catheter exchange or a catheter insertion. I don't know. Other than that, I'm going to digress.
So I would just and again, this is total bias, but
Yeah,
I
right.
think you're talking about a tool or technology, right? So I would just say that one thing that we've incorporated within our dialysis units is ultrasound. And
See, I was going to say that.
I
I was going to save that, but go ahead, Dr. Nair.
So
Go ahead, go
I
ahead.
think other than obviously education of the people who are doing this, and that paradigm needs to change. And I'll give a little plug for this. Through ASN, we are doing something called TDAT, which is Transforming Dialysis Access Together. And our website is up, you guys can see that, but what we are doing is really creating educational videos for everybody involved in dialysis access care. So definitely for general nephrology fellows who don't get exposure to this, but also we are not making everybody an intervention nephrologist. We are creating a tool that allows people to be educated about what they need to know to optimize care for the patient on dialysis. And we have created interdisciplinary committees. So we have obviously physicians, we have nurses, we have technicians, we have patients. And so just take a look at tdat.org when you get a chance, because that will have educational videos and all of that information on there. But I feel the one thing that we need to do is when you look at all the technologies. So the transonics, when we tried to review it, how much was it?
$36,000.
$36,000. It doesn't, the data isn't there, it doesn't support it. And ultrasound is $2,000. So what we did was, we kind of said, if we can use ultrasound to put in lines and we can put ultrasounds to do biopsies, but who's the person who's in the dialysis unit all the time? It's our staff. But we are not giving them the ultrasound. So what we did was we created an educational protocol to teach ultrasound. We had sim models that we made at home, Metamucil, gelatin, and like with a Penrose drain filled with water. Everybody got to try the ultrasounds. And when you think of the expense of dialysis, when you think about the reverse osmosis, the water, all the equipment, each dialysis treatment is so expensive. And that happens 3 times a day for 3 times a week for each patient. 1 ultrasound for each unit, we have 7, at the time we did it, we had 750 dialysis patients. 4 units, 4 ultrasounds, $8,000 investment, and they're still working. And what we've trained, and we have great, obviously Forrest is amazing. Forrest also works with Rodella, who's our wax lab, who had 0 ultrasound. I don't think a lot of our nurses had seen an ultrasound before. After the first educational protocol workshop, everyone said, if you don't buy us this ultrasound, we'll spend our own money to get it. So if I can suggest something, even though, keep in mind there's a bias because I'm very passionate about it, I think getting a small little ultrasound and being able to see, we have cases and cases. We had a patient who came in and they had gone for vacation, ended up having an episode, had something happen to them, and my staff couldn't cannulate it. We put the ultrasound on, you could see a stent. You can then mark the ultrasound on the fistula where you don't have a stent. Ideally, we can talk for stents, for another hour, but we won't talk about that. But you can use it for marking a patient who has aneurysms. There are areas where in between the aneurysms, you can mark the axis. New axes we've published on our protocol. Forrest is one of the authors on the paper. And we've really shown that we were able to decrease the infiltration rate. We were able to evaluate every axis at the bedside. And we combined, for your rural areas, ultrasound with telemedicine. So we would do the ultrasound in the dialysis unit. I had my surgeon call in to the dialysis unit. And we can then actually make decisions so the patient doesn't have to go for appointments. They don't have to go anywhere. They know right then and there what's going to happen to them. So if you think of one technology that you have a high return on your investment, it would be learning to use ultrasound and actually putting it in practice, other than your physical examination.
I agree. Now, I've been trying to convince a couple of corporations they should do this. And because the NKF or the NIDDK has mandated it, they are not doing it.
So LDOs have approached us, and I'm very surprised that after they talk, they are very excited about wanting to incorporate it into. I've met with CMOs of DaVita and Fresenius, no other LDOs, but these two. And every time the conversation is always, we are going to put it in our units, and then it doesn't happen.
Yeah.
So I'm not sure what the holdup is. In fact, maybe I know.
They think of all the thousands of units they have across the country, and if you put it in one or in an area that other people can ask for it.
My goal is it will become the standard of care.
I think it should be.
In 5 years.
Let me tell you something funny, if I may. I'm a dialysis technician. So when she said, we're going to start using ultrasound, I said, okay, you're going to send me to ultrasound school. No, I'm going to show you how to use it. So it's once you get it, it's easy. And the more you get it, you get better at doing it. I can detect some things like stenosis. I can detect, this is thrombus. You know exactly the target to cannulate, where not to cannulate. We have a protocol where when you first come with a new fistula, the second week I'm on it. We're measuring in increments, looking for the depth and the diameter of the fistula. Then we do it again. And it's no secret. If it's not maturing, you're gonna send them back. Where some people, look, I got a fistula. I've had it for 6 months. Really? No, you send them back and get it done. Because we know the instance of access is not performing correctly is 30 to 60%, by the way, okay? So this is really effective. Also, when you show the the technician and or the patient see that? Because it has a color Doppler, ours does. Wow, look at that. You see red and blue, there it is. And speaking of that, we got a protocol. If you use it and the color Doppler is black, my saying is no flow, no go. It's clotted, it's thrombosed. Because the worst thing to me that can happen is your master cannulator, your expert cannulator, oh, well, you can't get it, so I'll come over. They don't even assess it because they know so much, and they stick clotted access. I said, what are you guys doing? Well, I listened and I felt a pulse. I'm impressed. You felt the pulse. You have to do the whole physical exam. Well, that's, so things like that perturb me, you can hear. So, okay, what else are we gonna talk about? Okay, any more questions? We have,
Yeah, so it's just about cannulating. So
Yeah.
essentially we teach the ladder, you know, you're trying to go
Yeah.
up and up, and so you don't create aneurysms. But there are some people that I feel are just more prone to getting aneurysms. And I feel that sometimes with patients and, you know, definitely the staff, they try to go up and either infiltrate it or it doesn't work, or maybe something's, I don't know. And they continue to use close, you know, essentially the
Same area.
the same site, and we get aneurysms. And then I specifically have a hard time assessing the aneurysm. Like, people will go on the side, of course, not on top, but I'm like, how, it's like a blind stick as far as I'm concerned, trying to go to the side of the
Well-
aneurysm. So like, how do you stay away from that and then ultrasound?
you know, well, you wanted that thing, or?
Like some
You got
tips
it?
and tricks to be able to tell people, like, stop going to the side of that aneurysm. I think this probably is making it worse. Like, let's just kind of go up higher or down or someplace else.
So the problem starts downstream, right? A surgeon who creates the access never comes into the dialysis unit to see what's actually happening with the access.
Yeah.
So it could be that the access has issues, because if you have a small brachiobasilic,
Yeah.
you know, you've got a proximal swing segment that
Yeah.
Forrest told you earlier that will probably have stenosis. So you have to stay, you know, a few, 3 fingers away from the anastomosis, and you now can't stick the proximal swing segment, so you have a little area.
Yeah.
So that's a problematic access to start with. So one thing that we've done in our units or in our center, and we have the luxury of that, is that we actually brought everybody to the table, and we've started educational protocols where we bring the surgeon to the dialysis unit, and we take my nephrology fellows to the interventional suite, because that's the only way you can see what the other side is doing. So that's one problem. The other issue is when you have an access like that, you have 2 options. One is that you know, you do rope ladder and you're sort of closed and you come back. The other option, which is a much maligned option, is a buttonhole technique. And the buttonhole I would reserve only for, and I know we've got Canadians here who talk about infections in buttonholes, but in the right hands, in a single patient self-cannulation. So I don't really like buttonholes, and we won't do buttonholes in our patients if there are multiple cannulators, because there's no way that you're going to go in all 3 layers at the exact same angle as somebody else. It's just not going to happen. But in the right patient, that is a person I would consider for someone who has buttonholes in a short brachiobasilic segment. The other thing that you can identify in advance, even if you don't have the ultrasound, is a good physical examination, because things curve.
Yeah.
So you might have a brachiocephalus. So we're running out of time.
Yeah.
We can talk on access forever, but
Yeah.
we are running out of time, so people can stay back if you want to, and we are happy to keep talking. But time apparently is over. But, you know, so brachiocephalics is the other thing where you've got an angle, so you've got to, we just, you know, use the ultrasound to give you a longitudinal and a transverse. Yeah.
I like it.
Okay.
One more thing real quick on aneurysms. Most aneurysms, other than what she alluded to, are caused by us. You have inexperienced or new people or people who are afraid, and they go where the first one went. See this? They keep going.
Or you missed it, or you missed a physical examination finding that you should have identified, because
That's
you don't
right.
want that pressure to build up over a long period of time.
Or they're afraid to talk to the patient because the patient are like, no, here and here.
Yes,
Yeah.
yes, yes. You have to educate the
So
patient.
we have to have
Always.
the confidence to educate the patient you know, and saying again, this is your lifeline, you want this to last as long as possible, if we keep going in these same two areas, blah, 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 you know. So, yeah.
So yes, we are at the end of our time, but we will stay here and continue to answer questions if you have any. I do want to remind everybody, please make sure that you go on and you do your pre-test and your post-test, and that way you can get the credits. They need to be claimed by May 29th. So we'll continue to answer your questions though.